He'll be joining us soon. He's already joined actually. He'll be coming too. And we are going to have a good discussion on glaucoma. Part of this program is being sponsored by Novartis, and welcome them also to this program. And the third will be a case discussion from one of our PG students from Thrissur Government Medical College. So I'd like chairs to take their places. Dr. Merrill and Dr. Srini will be chairing this session. And Dr. Shobha will be introducing the guest speaker.
Can I request everyone else than the speakers to mute their microphones, please?
Shobha will be introducing the guest speaker.
Can I request everyone else than the speakers to mute their microphones, please?
Okay, Shobha, can we start?
Speakers and come, no? Has a speaker come?
No, he will join now.
Okay. Shall I start?
Conductor. Okay. Please start.
Good evening, everyone, and welcome to tonight's TACO monthly Zoom meet. It's my privilege to introduce today's guest speaker, Dr. Arvind Kumar Moria. He is the additional professor of ophthalmology department at the All India Institute of Medical Sciences, Hyderabad, and he heads the cataract, glaucoma, refractive surgery, squint, pediatric ophthalmology, and the medical retina services. Almost the entire gamut of ophthalmology, I think. And he has to his credit around more than 300 international and national paper presentations, and also more than 50 international and national publications in peer-reviewed journals. He heads many projects based on the artificial intelligence on diabetic retinopathy, glaucoma, and Alzheimer's, and is also the National Medical Advisor for the COVID screening trial based on artificial intelligence. Dr. Arvind has won many awards. Just to mention a few, he is the first to receive the AIOS Senior Academic Achiever Award of 2021. He has won the Teacher in Ophthalmology Award at the International Beach Festival 2019, Best Surgical Video Award in Roscar 2018, and also he is the Associate Editor of the UK JOS, the Assistant Editor of IJO, and he assists in all the journal reviewing, and he's a reviewer of the famous Elsevier Clinical Ophthalmology book. So my fellow ophthalmologists, it's a very brief biodata of our speaker, Dr. Arvind Kumar Mora, and on behalf of TACO, I invite him for his talk on Phacotrabeculectomy with Ologen. Welcome you, sir.
Thank you, ma'am. Thank you for the nice introduction. Am I loud and clear?
Yes.
Thank you so very much, Thrissur Academic Club of Ophthalmology. And thank you, Dr. Sudhavi, ma'am, Dr. Sujata, Dr. Ronald Godley, Dr. Seenu, ma'am, and special thanks to my dear friend, Dr. Srini. Thank you. Thank you. So I shall start with sharing my screen. Can the IT guy allow me to share my screen?
Yes, please do. Please share.
And special thanks to my dear friend, Dr. Srini. Thank you. So I shall start with sharing my screen.
Dr. Moria, I think there is an echo coming.
Share my screen?
Yes, please.
Yes, sir. We can see your screen.
Okay.
Please carry on.
Shall I full screen?
Yeah.
So my today's talk is regarding a combined Phacotrap with Ologen, the biodegradable implant, in a one-eyed patient of chronic congestive glaucoma. Am I audible? It's not echoing now?
No, it's fine.
Okay. So first I will play the video.
72-year-old male diagnosed with left eye nuclear sclerosis, grade 3 cataract with chronic angular glaucoma.
Yes.
Yes.
In other eye is planned for combined phacotrabeculectomy with Ologen matrix implant. His preoperative vision was 6/60 in left eye and the maximum IOP is 43 mm mercury. The eyeball is deeply seated and after giving peripalpal blob, a severe subconjunctival chemosis happened. A superior rectus bridal suture was passed and following which a conjunctival peritomy was done in a severe chemosed conjunctiva. After removing tenons, a wet field cautery was done to reduce the chances of subconjunctival bleeding. Following which, a limbal-based scleral flap, triangular in shape with apex reaching towards the fornix, is made using 15 number blade. The scleral flap should be half thickness of sclera. The thin flap may cause a buttonholing of scleral flap. After giving the scleral incision, the scleral flap is raised till the corneal margin by using crescent. A side port entry into AC was made at 10 o'clock, following which air trypan blue dye was injected and it was washed. The AC was reformed using viscoelastic substances. A continuous curvilinear capsulorhexis was done using 26 gauge hypodermic needle. The capsulorhexis was quite difficult in this case due to small pupil as well as shallow AC. In this case, the viscoelastic substances should be used little or in moderate amount for formation of AC before doing capsulorhexis. A main port entry was made using 2.2 mm of keratome at 12 o'clock beneath the scleral flap, following which hydrodissection and hydrodelineation were done. Floppy iris was noted. The nucleus was maneuvered and rotated using a Sinskey hook. The pupil was further constricted and the subsequent steps become quite difficult. Iris prolapse was noted and it was repositioned using iris repositor. A cohesive viscoelastic substance was injected in AC in little to moderate amount for AC deformation. The phacoemulsification process was started by using phaco probe and the chopper. First, the nucleus is divided into two pieces. A sculpt was made. Thereafter, the phacoemulsification process was completed by direct chopping technique. The phacoemulsification parameters were kept in the lower range due to small pupil and shallow AC. The cortical matter was removed using Sinko's cannula. During irrigation and aspiration, a sudden bradycardia was noted and was managed appropriately by anesthesiologist. foldable posterior chamber intraocular lens was implanted in the bag. Viscoelastic substances were removed using Simcoe's Ganga. Scleral flap was lifted and scleral piece above the trabecular meshwork is excised using MVR blade. Peripheral iridectomy was done. The prolapsed iris is repositioned using iris repositor. Corneal side ports were hydrated. Air is injected in anterior chamber for anterior chamber reformation and scleral flap is repositioned and sutured at apex using 10-0 nylon, followed by suturing at right and left arm of the scleral flap. An Ologen matrix implant was placed beneath the conjunctiva and the conjunctival closure was done using 80Y3. Implantation of Ologen in the subconjunctival space offers a new opportunity to prevent the complication associated with mitomycin C augmented filtering surgery such as corneal endothelial cell loss, cystic thin vascular bleb, choroidal detachment, and endophthalmitis. Moreover, Ologen is composed of porous matrix that can induce fibroblast growth, leading to a well-organized and healthy healing process. And the remaining conjunctiva is closed using cautery. Despite so many complications and difficulties during the surgery, during the post-op period, the patient's vision is improved to 612 and the IOP was reduced to 9 mm of mercury with a functional conjunctival bleb. Combined phacotrab surgery in a case of angle closure glaucoma reduces the chances of chronic angle closure in 25% of cases according to some studies. "72-year-old
So there were many complications and there were pre-existing problems also. One, it was a one-eyed patient. Other eye was totally lost. That was absolute eye. And also this eye, the IOP was quite high and around 43. So we planned accordingly. So first problem was regarding the deep-seated eyeball. So to prevent, to have a better exposure, we can do these steps. So first is the superior rectus bridal suture. So it gives us more exposure. Then the head is still temporarily slightly. So it provides space as well as it's avoid pooling during the intraocular surgery. And also peribulbar block is given. That also provide slight proptosis at least for some time. And if we need more exposure, then the lateral canthi, there we can give the relaxing cut. And again, it can be sutured. And I prefer to use the adjustable eye speculum for maximal exposure. And chin elevation with proper and comfortable head and neck support so that the patient is comfortable as well as we have proper exposure. And trimming of eyebrows and eyelashes can be done for better visualization and suturing becomes quite easy. Also, there was subconjunctival chemosis. So we need to differentiate it with the RBH. And pressure is always given intermittently, not continuously, to make eyeball soft. And gentle cautery, avoiding the conjunctival margins. And single side phaco and trab was planned. To prevent poor visualization, we can use glycerol eye drops. Yes, of course, after controlling the intraocular pressure. it must be below 20 if possible. Then the pressing the central part of the cornea with the bud. And if still the visualization is not so good, so we can do epithelial debridement. And also we can place 2% HPMC over the cornea for better visualization. Also, there are retroillumination and chandelier system to have a better visualization. Also, small pupil was there. So we can do viscometriasis or intracameral dilated adrenaline can be used, and Y-shaped IOL dialer to stretch the pupillar sphincter, and they are placed 180-degree apart until the limbus at least for 10 seconds of duration. So have a very good dilation. And if that fails, sphincterectomy can be done. 3 small radial cuts on the sphincter pupillae, 120-degree apart for proper capsular axis and exposure, but not at 6 o'clock position in this case, as the iris will start coming into the phaco tip. So it must not be given opposite to the main incision when we are doing phaco. And then, of course, iris hooks and BHACs, they can also be used to deal with the small pupil. Also, this was a case of low endothelial chamber depth of less than 2.6 millimeter. And this was a hypermetropic eye. So moderate visco is given to prevent the uveal tissue prolapse. And soft gel technique is used, and repeatedly 2% HPMC coating towards the endothelia is preferred, and gentle maneuvering of instruments, whether they are blunt or sharp. And phaco needs to be done at low parameters. All steps under direct visualization, avoiding equatorial maneuvering, stop and chop or only, avoiding iris chafing. And the nucleus pieces needs to be brought in the iris plane, and central emulsification of nucleus pieces should be preferred. Least exposure of phaco tip and use of 2.2 millimeter phaco tip if possible, so that least of the energy and the endothelia that is protected. Least entry and removal of phaco tip. It should be completed within 2 or 3 times, preferably within single shot or in the second time. And we can attach the Simcoe cannula to irrigation aspiration of the phaco tubings for better control in such cases. And during the trabeculectomy, the fornix-based conjunctival flap, I prefer this kind of flap, so that I don't need to go behind, because in deep-seated eyeball, you need more exposure, so it's not possible in such cases. Then triangular scleral flap of proper thickness to avoid buttonholing, and ostium I prefer 2 into 1.5 millimeter. And 1 central tight and 2 slightly loose sutures are given. And I prefer to use the biodegradable Ologen implant in such cases instead of the adjunctive therapy of 5-fluorouracil or the mitomycin C. They are successful, but there are complications like the bleb-related infections, bleb dysesthesia, bleb leaks, and endophthalmitis. So what is new about this biodegradable Ologen implant? It is a plate-shaped, tissue bioengineered, biodegradable, porous collagen glycosaminoglycan matrix used during trabeculectomy. And this device randomly reorganizes the regeneration of myofibroblast, fibroblast, and the secreted extracellular matrix, and consequently reduces post-operative scar formation. And investigators have reported that Ologen implanted in the subconjunctival space provides an alternative method or an adjunct to antimetabolites for controlling the wound healing process and reduce the complications associated with the use of antifibrotic agents. So it's a small video. It comes in 2 sizes, 6 into 10 into 6 into 2 millimeter size. So there is a controlled drainage. You can see it's a mechanical effect, and it reorganizes the fibroblast and the myofibroblast randomly. So it prevents that stele of scarring formation that is seen in a lot of cases in trabeculectomy. It takes 3 to 6 months for complete degradation. Finally, there is physiologic collagen deposition, and there is a functional blab with normal conjunctival structure. So the take-home message is take challenging cases once we are confident enough and experienced enough, and proper planning, discussion with fellow surgeons and seniors and watching videos should be done when we are going to operate such complicated cases, and proper instruments must be ready before the surgery, and proper counseling and consent regarding the realistic results in such cases is a must. And these requires longer follow-ups. We need to be innovative, but with calculated risk, and expectations are and will be part of our life. Thank you. Be a lifelong student. The more you learn, the more respect you earn, and more self-confidence you will have. Thank you. Thank you so very much.
Thank you, Dr. Arvind. That was a fantastic presentation. Dr. Srini, can you also join?
Yeah. Somehow I can't open my
video.
I can't see you, Srini.
Yeah. I'm not able to do it. Somebody has blocked me out.
Yeah, Srini, you can just switch on your video.
No.
The host has to. 1 second, Srini.
Yeah.
Sudha, can you ask the host?
Yeah. I am doing
allow
it.
us? Yeah.
That's okay. You can hear me, right? Arvind.
Srini, you can start the video.
Yeah.
No, it's not happening. I'm blocked out. That's okay. It's you cannot start the video because host has stopped it.
Srini, you can switch on the video. Yeah.
Now it is fine.
Yeah.
Yeah, we can see you. Finally.
Arvind, see, have you faced any complications at all with the use of Ologen? And among all the trabs that you're doing, are you still using mitomycin, or all you're using Ologen? And being in a government center, do you have a constant supply of Ologen at your center, or in some cases you have to use mitomycin because Ologen is not really available?
Okay. Number one, regarding the use of mitomycin C, I am still using it. No. And regarding the Ologen, yeah, we have a constant supply. We have that L1, I think, is the tender formation that is there in the government supply. So we can use it depending on the patient. I prefer to use in the pediatric patients and in the congestive glaucomas most of the time. In pediatric cases, I sometimes, when we are dealing with the Axenfeld-Rieger syndrome, so there is limbal stem cell deficiency already. So we can't use this mitomycin C in those cases. So I prefer Ologen. So I use half of the Ologen in pediatric Buphthalmos cases or the Axenfeld-Rieger cases. So that half pieces is enough in pediatric cases. And in adult, single, that 6:2 I prefer.
So one question, Dr. Maurya. See, now we are getting more and more studies saying that efficacy of Ologen as compared to MMC is almost the same. In that situation, given that MMC has much more, adverse effects, why would we continue to use MMC in any situation? Because even I think now Sturge-Weber's and, like you said, Buphthalmos, these are cases where Ologen has to be proved to be successful. So can you give us the rationale why we still should use MMC in select cases, and if so, which cases?
Very good question. I completely agree with you. But let me put all these things. When we are doing a simple trabeculectomy, it's 7,000 at our center. And when we are doing it with Ologen, the cost rises. It's 18,000. So not everyone can afford it.
Right.
the powers of medical superintendent and director is 10,000 only. So we are doing that part also. But still that price, that cost is there. And I think we are getting it on a very low price. But in private sectors, there again a problem.
So basically cost
has been always a problem. Yeah.
So ideally right now.
Madam, can I make a small comment?
Yes.
Yeah.
Sorry?
Yeah, I just wanted to make a small comment regarding this. I think one should not go away with the impression that the sum total of results of Ologen traps versus MMC traps in terms of efficacy is the same. That is not correct. There have been two meta-analyses published on Ologen traps.
Yes.
The first was sometime in 2013. That was a Cochrane review. People who follow Cochrane meta-analysis would know that in Cochrane meta-analysis, it is usually very difficult to find a difference between two treatment groups, whatever treatment groups they are. In the Cochrane meta-analysis, there was no statistically significant difference between the two arms, but there was always a trend towards better IOP control with mitomycin. And subsequently in 2017, I'm not exactly sure, 18, another meta-analysis was published, and that is actually showing better intraocular pressure reductions with mitomycin traps. So if you look at the sum total, I think efficacy wise, we should consider the fact that mitomycin is going to be more efficacious, but at the risk of higher complications. Obviously, because in glaucoma, as far as I know, there has been not a single method of surgery devised where you can achieve greater intraocular pressure reduction and lesser complications of hypotony. So that is the basic holy
grail.
Agree with this. Yeah.
But Dr. Kiran, can you just enlighten us on this, that you said there is a statistically significant difference in the meta-analysis.
In one of the meta-analysis that was published in 2017.
The second one,
yes.
In the second meta-analysis, that statistically significant difference was coming down, because the earlier study showed much more difference.
There are two reasons. I will put it this way. The subsequent meta-analysis was done with more data. All right.
Exactly.
Was more data.
So what I wanted to know is whether if it was really statistically significant or was it clinically significant.
The second meta-analysis, if I remember correctly, the problem is the last time I made a presentation on Ologen was at least 3-4 years back. So I'm not very well versed with the literature. I remember going through the Cochrane meta-analysis very clearly and showing that there was a difference, but not statistically. Sometime back. But I think, look, I started putting Ologen sometime in 2009 when I was a senior resident at Ames, and Dr. Tanuj, my boss, was doing a lot of work on Ologen implants at that. We just come up at that point of time. And very early on, we realized that the bleps, it was actually appearing more vascular, etc., during that time frame. And in fact, he actually published this. He actually devised a method by which you can actually use a lower dose of mitomycin C along with Ologen in cases, this is a little controversial. Obviously, he has only published case reports, but a lower dose, instead of the 0.2 milligram per ml, you use something like 0.1 milligram per ml, and then use the Ologen implant also. So the whole idea is to reduce the possible side effects of mitomycin C, which is dose dependent, because it is very clearly established that 0.4 milligram per ml is the ones which create maximum hypotony related complications. And then you use the Ologen implant to kind of, modulate the fibroblasts. The controversy theoretically is that if you were using mitomycin C, mitomycin is supposed to be like a bomb. It actually kills the fibroblasts. And if all the fibroblasts are killed, then the Ologen implant will not have any fibroblasts to modulate. Right? So that's a theoretical argument. But I think what is obvious is that there is always a tendency towards higher intraocular pressures with the Ologen traps, but with a much more safety picture in mind. As Dr. Arvind pointed out, he mentioned specific cases where this could be very, very useful, because there are specific situations where you had higher risk of complications. He mentioned about limbal stem cell deficiencies in certain cases, and and certain specific cases like young myopes and all, where you are at high risk of developing post-op hypotony and all sorts of complications. Those cases, Ologen has I suppose, a significant role.
So, Dr. Arvind, if cost was not an issue, would you advise Ologen as a primary Ologen trap as a primary procedure?
Ma'am, I have done more than 235 cases now. So I'm very much comfortable with Ologen now. Results are means constant and the very good IOP control. And the complications were in the initial cases, in the first 20 or 25 cases.
What complications?
So now means low IOP.
Low IOP.
Very low IOP. In 2 of my cases, in the first 25 initial cases. Our study is ready, so we are going to publish it. So that was the problem. So now I'm well versed.
How do you explain that? Low IOP, very low IOP with Ologen?
Actually, in those cases, we were putting in the flap. The Ologen we were putting in the flap.
Inside
okay, now we are putting above the flap. Yeah, yeah.
Yes, we have also done that inside the flap, and then we had to cut the Ologen into 2 and put it inside the flap and suture it. So that, so that has worked well. But like you said, initial days you have to, most of those cases has to be tightly bandaged. But yes, it works beautifully.
And you do it with a rectangular flap. Huh?
Yes, yes.
The round flap also, Dr. Sudha.
Rectangular flap, yes. One more thing, actually, another issue would be when you are doing phacotrabeculectomies, if you generally, if you perform traps alone versus say phacotraps, phacotraps always tend to have, in open angle glaucomas especially, tend to have slightly higher intraocular pressures. Generally, you get pressures like 12 to 16 rather than the 8 to 10 you get in plain traps. And these are situations where you want to do some suture modifications, either in the form of suture lysis or some degree of bleb needling, and that is going to be a problem if you have Ologen inside.
So would you advise that you do cataract and as two procedures? Instead of doing it as a single procedure, would you advise that you go for a 2-step procedure?
I prefer single step if the IOP is well controlled. So I prefer single shot.
Yes, reduces cost and also trouble.
Yeah. Even single phacoemulsification, it reduces the IOP up to 30% for 5 years, 3 to 5 years.
Yes.
In the consistent
especially
glaucomas.
in narrow angle, especially in narrow angle.
In more than 50 of my cases, phaco alone is helping.
Dr. Arvind.
Sir.
What would be the success rate, say, in normal cases? Say you do 100 cases with Ologen, what would be the percentage of success?
Success,
functioning blebs, yeah.
80%. 80%.
80%.
In longer follow-up of more than 5 years.
As opposed to nothing else. No modulation. That is right, no?
Yeah. In 20%, we are doing needling, and we are then going for implants also, because some cases are, even after giving medication, adding, we need another surgeries also. We can't help it.
Yeah. And Kiran, with mitomycin, what is your success rate?
I actually don't have any data on, I haven't done any comparisons.
Yeah.
The thing is, I don't use Ologen alone. I still use a very low dose mitomycin along with Ologen whenever I have to use Ologen. In fact,
I'm saying mitomycin, not Ologen.
Mitomycin alone.
Yeah.
I think it should be in the 80 to 90% category, but to be very honest, I don't have any data like that.
Okay, that's fine. Yeah. I use 0.2% for 3 minutes.
Yeah, that is my standard dosing as well.
Yes.
0.2 for 3 minutes if I'm using MMC trap alone. And if I'm using it along with Ologen, I will use 0.1 for 3 minutes. 0.1 for 2 minutes actually, and then put in the Ologen implant.
Right.
But one thing is very clear is that you hardly get any flat chambers and extreme hypotonies with Ologen. I suppose obviously the mechanism is there, and plus the fact that I suppose it has this the mechanical effect of the flap getting pressed down also has a role there. So you can sleep better when you have put in an Ologen.
And even late complications of mitomycin,
obviously, yes,
much more lesser. So it is far safer if you would get the same this thing. Yeah. Anybody else has any questions?
Can we use mitomycin when we are trying single site surgery, single site phacotrab?
No.
No.
Then I will do at 2 places.
Yeah, 2
Different sides.
places.
Yeah,
Okay.
2 sides. Yeah.
But Ologen, we can use that. That's
Yeah,
another
we can
advantage.
Yeah.
Yeah.
Kiran, what is your opinion regarding subconjunctival mitomycin?
Yeah, it works perfectly well. Perfectly well. If you are using mostly subtenons, basically, it's almost like subtenons, you give a mitomycin, and then you can proceed with your trabeculectomy. The literature is clear on this. I have tried it only 2 cases. My colleague, Dr. Thomas George, is practically now doing all cases with subconjunctival mitomycin followed by. He feels that he can makes the surgery faster because you can actually give the subconjunctival mitomycin at the very beginning, and then do the conjunctival peritomy. Unlike in the other situation when you open the conjunctiva and then wait for 3 minutes by putting the mitomycin C. So that doesn't, but I think there should be no reason why it should work any differently.
Right. So anybody has any other questions? Then can we move on to our next talk with Dr. Kiran?
Yeah, short. Can I share my screen now?
Dr. Kiran, I think Dr. Shobha is waiting to introduce you.
Oh, okay. I didn't give anything for introduction, so
Nope.
Everything is there online. Kiran.
Yeah. Okay.
Okay, now for the second talk of the day, we have Dr. Kiran Gopalakrishnan. He's our own KSOS member, and we have heard him a lot in all the conferences. But still, I have to introduce him. And he completed his MD ophthalmology from the All India Institute of Medical Sciences, Delhi in 2008, and worked as senior registrar for 2 years after that at AIIMS itself. And then he joined the Vasan Eye Care Trivandrum for 4 years. From 2014 till the present day, he's been working as senior consultant in glaucoma at Precise Specialty Eye Center, Trivandrum. He has presented various papers and participated in almost all the drishtis as in instruction courses as well as paper presentations. And also he's published data in articles in peer-reviewed journals also. Now he'll be speaking on the topic timolol brinzolamide, a fixed dose combination and overview. And I invite you for your talk, Dr. Kiran.
Thank you, Dr. Shobha. Shall I share my screen now?
Yes.
Yeah.
So it shows that even without giving introduction, giving the introduction, you're very famous, Dr. Kiran. Welcome.
Is the screen visible now?
Yes.
Yeah.
Yes.
Thank you. So we will just have a quick overview of the timolol brinzolamide fixed dose combination. So I'll be basically looking at 2 questions. First of all, why fixed dose combinations? And the second question is basically a quick overview of this particular fixed dose combination. So we will try and answer the first question, why fixed dose combinations? So we look at fixed dose combination general. Whenever you use an FDC, you are always going to use lesser number of drops. So this is expected to create lesser side effects, better compliance, and obviously the risk of washout phenomena is also going to be much lesser. When you talk about compliance, there are 2 things that immediately come to mind. One is adherence and persistence. So adherence is the degree to which a patient follows instructions, and persistence is the time. All right. So we'll just a quick example of what I mean. Adherence means, suppose you have prescribed a drug twice daily for 30 days, and if the patient is taking it twice daily for 10 days, his adherence should be 33%. And if you are looking at persistence, we are looking at the time frame. So we have prescribed a drug for 3 months and he has used it for 2 months. The persistence is 2 months. So let us look at data. So what is very clear is that if you take data on patient adherence and persistence in compliance in general, from wherever, whichever geographical area, whether in the US, New Zealand, India, any place, you will always find that there is a lot of deficiency with respect to compliance. So up to 50% patients stop taking medication within 6 months. This is from the US data. In fact, there was a very elegant study conducted in the Aravind Eye Hospital, Coimbatore, which actually showed that nearly 75% of Indian patients failed to attend at least one follow-up visit over a period of 1 year. You have to understand that this was actually obtained from patients who had followed up at least more than once, So this was actually part of a retrospective analysis. So you can imagine the total number of patients who actually failed to follow up. So the essential importance is that patients do not take their medications as prescribed. This is well established in literature. And there are a lot of barriers why this happens. Sometimes it's a difficulty in drop administration, poor knowledge, difficulty with medicine schedules, cost, a lot of factors. But at least 50% of patients do report pain and discomfort with their medication. And this is well established. So with multiple medications, there is usually a huge problem. When you shift from one medication to 4 medications, there is usually a drop of adherence by nearly 31%. And when you shift from a unfixed combination to a fixed combination, you have almost a 20% increase in adherence. Plus the fact that when you use multiple medications, a greater load of preservatives and the active ingredient, and therefore you are more likely to develop corneal surface disorders as well. So what are the variable fixed combinations we have available for glaucoma management? I'm not going to the details. These are all fixed combinations we know. In this particular list, this particular fixed combination of nitazoxanide latanoprost is currently not available in India, though has been approved by the US FDA. All the others are available. So it is the brinzolamide timolol comes under the situation where it in this particular family. So let's actually look at this. So basic chemistry, brinzolamide and timolol. Brinzolamide as a carbonic anhydrase inhibitor and timolol as a non-selective beta blocker. So let us consider some basic literature. So whenever you have a fixed dose combination, it has to be conclusively proven that this combination is going to be more efficacious than the individual drugs. Sounds very simple, but actually this does not work in all cases. For example, the prostaglandin timolol fixed dose combination, a lot of studies actually does not show any beneficial effect over prostaglandins alone, which is one of the reasons why the US FDA has not approved prostaglandin timolol fixed combination. So in this case, we are considering the BT, that is brinzolamide timolol with brinzolamide and timolol separately. This was part of the initial trials that helped in approval. So you have 3 arms, the fixed dose combination, then the individual brinzolamide arm and the individual timolol arm. And it is very obvious that at all time periods of the day, this combination works better in terms of intraocular pressure reduction than the individual drugs. And if you compare the safety profile, it is similar. So whatever side effects you can expect with brinzolamide or timolol, you will expect that in the fixed dose combination as well. Now, its closest cousin is the dorzolamide timolol fixed dose combination. Therefore, this comparison needs a little bit of understanding. So there have been a lot of studies which compares these two drugs. This was a multicentric study conducted in both Europe and Singapore. And this actually compares the two combinations, the brinzolamide timolol fixed combination and dorzolamide timolol fixed combination. And it is very obvious that both are similarly efficacious in terms of intraocular pressure reduction at all time points. And this has been replicated in any number of trials. When you look at the adverse drug reactions, you find that the total number of adverse drug reactions is slightly more in the dorzolamide timolol group. And this is mainly because there is higher incidence of irritation and eye pain with the dorzolamide timolol fixed dose combination. And this is expected because of the acidic pH of the dorzolamide timolol fixed combination compared to the more physiological pH of 7.2 with brinzolamide timolol fixed combination. But at the same time, you'll also notice that there is a temporary blurring of vision that is induced in more patients with the brinzolamide timolol combination, and that is because it's a suspension formulation. So this is something that you need to tell the patients beforehand. And as I said, this has been replicated in a large number of trials that efficacy remains the same between the two, but in terms of adverse reactions, the stinging and burning and irritation will be higher with the dorzolamide timolol group. The temporary blurring of vision will be more in the with the brinzolamide timolol group. Just because you have higher stinging and burning sensation in one group and higher incidence of blurred vision in another group, that does not mean that the patient might prefer one study over the other, one group over the other. So this particular preference study group looked at this particular theory, and they found that because the ocular discomfort scores are consistently higher on the dorsalamide timolol group, nearly 80% of patients actually tends to prefer the dorsalamide timolol combination over the brinzolamide timolol combination. This is a crossover study when the drug was instilled on consecutive days, which looked only at the preference of patients. And now let us consider this fixed combination with all other fixed combinations which are available, and also with prostaglandins. So this is a meta-analysis which looked at prostaglandin monotherapy and all the other fixed combinations, which contains both prostaglandins and the beta blocker containing. This is the prostaglandin plus fixed combination, and this is the beta blocker plus fixed combinations. There are some interesting data. First is, when you use prostaglandins as monotherapy, it has similar efficacy as beta blocker plus fixed combination, which means, what it means is, suppose a patient is on prostaglandin monotherapy and you want to shift him out of prostaglandins for any other reason. Maybe it's because of the hyperemia, whatever reason. You cannot substitute it with a monotherapy because no other drug can match prostaglandins with intraocular pressure reduction. So you will have to use a combination therapy with something like brinzolamide timolol or dorsalamide timolol, any other fixed dose combination. You cannot get away by using a monotherapy as substitution. The other thing is, in this meta-analysis, what was very obvious was prostaglandin plus any other drug does not seem to have a significantly great effect over prostaglandins alone. As I mentioned earlier, this was particularly noted with timolol, and one of the reasons why this combination of prostaglandins and timolol has not been approved by the FDA. One thing that comes out on the meta-analysis very clearly is that any combination of drugs that does not contain prostaglandins will always produce less hyperemia than prostaglandins. So to summarize, any fixed dose combinations have a positive effect on patient compliance and should be used wherever it is indicated. Brinzolamide timolol fixed dose combination has comparable efficacy to the other fixed dose combinations, all the other fixed dose combinations, not just dorsalamide timolol fixed dose combination. It has a better ocular comfort on installation versus the dorsalamide timolol fixed dose combination. So practical indications: any patient who is on PGA monotherapy and is complaining of hyperemia or other local side effects of prostaglandins, and you want to shift him out of it, you can consider this drug as a possible option. Similarly, a patient is already on dorsalamide timolol fixed dose combination and he is complaining of a lot of ocular discomfort, irritation, and stinging. And if you feel that his complaints are likely to translate into non-compliance, this is a good option. And the other thing is, as part of standard glaucoma regimen, just like any other fixed dose combinations, you can use this drug. Thank you.
Thank you,
That
Dr.
concludes my presentation. Thank you for your patient listening. Yeah.
Excellent presentation, and you have made a very dry topic sound very exciting, actually.
Okay.
Well done. So the discussion is open for questions.
Kiran, what is this? What about this add-on thing to prostaglandins? If it's not working, what about your experience with adding on fixed drug combination?
No. What I'm trying to say is, this is strictly with respect to the fixed drug combination. Prostaglandins are themselves quite, very effective, right? So what happens is that somebody is on prostaglandins and you are going to add one drug along with it. As let's say you are adding timolol along with it as a fixed dose combination. And surprisingly, if you look at all the literature, there are some studies which actually does show that the combination will work better than prostaglandins alone. But a lot of studies do not actually show this. And this is one of the reasons. You have to understand that none of the prostaglandin timolol fixed dose combination, though it is freely available in India, it has not been approved in the US.
It is available. It is available.
Yeah.
Bimati.
Yeah. Not in India.
In India, it is available. Yes.
It is available in India, not in US. That is what he's
FDA
saying.
Approval has not been obtained for this combination.
So another thing I would like to ask at this point is, actually, don't you think, because timolol, the maximum duration of, or rather the best efficacy is for 12 hours, right?
Yes.
And the other one is for 24. So how is it even actually a scientific combination when you're saying timolol with prostaglandin as a fixed dose combination? How does it work? How does the science work?
Yeah, that is why I'm saying that the literature is actually, because see, I'll put it very simply. You compare brinzolamide and timolol as unfixed combination and the brinzolamide timolol fixed combination. You take timolol brimonidine unfixed combination and take separately timolol and brimonidine. So you do that with any drug that does not contain prostaglandin. You will immediately find that the combination always has much more effect than the drugs
that
alone.
Could be, what I am saying is that would be possibly because those are all drugs which are given for given BD dosage.
Yes,
only prostaglandin is given as an OD dosage. So basically, when you are saying that you are putting timolol along with prostaglandin, that means at some point during the day, the effect of timolol is going to wash out, isn't it?
Yes, to a large extent, yes. I think the effect is 12 hours. Therefore,
so it is better to use timolol BD and prostaglandin over that.
That is probably better. But again, what I am saying is, whenever you do meta-analysis, sometimes even slight differences in intraocular pressure in favor of one particular group may not be actually picked up. Right. And when you are using, say, prostaglandin and timolol as unfixed combination, you have to consider the fact that you are now going to put 3 drops in the eye, or compared to just 1 drop. So you will have then a question of, as I mentioned, about adherence. So as the number of medications, adherence drops down. So that has also to be taken into consideration. When you are
also, the side effects are lesser, no? BKC.
Obviously, yes. But at the same time, when you are using timolol, the local side effects of timolol are probably the least among all the glaucoma drugs. So that itself may not be a big problem. It's the question of 1 versus 3 drops over a period of time. This does translate into poor compliance.
But the problem with these things is that we usually start with the prostaglandin.
Yes.
And then you add step by step. So it hardly, you don't, you add timolol or you add something, and then the fixed dose combination there becomes a little.
No, you can always, the basic dictum is to add 1 by 1. And once you are convinced of the efficacy, shift to a fixed dose combination, because that, as I said, may not work with timolol, but more than the side effect, I think the adherence would be the biggest issue with any combinations.
Right. Any other questions?
So brinzolamide with timolol is better than dorzolamide with timolol.
No, I did not say that. I did not say that at all. Let me make it very, very clear. Brinzolamide timolol and dorzolamide timolol, in terms of efficacy, in terms of intraocular pressure reduction, there have been at least a lot of articles when they are compared directly with each other. And also in situations where brinzolamide has been added to timolol separately and dorzolamide has been added to timolol separately. So both these, there have been any number of trials. Efficacy wise, there is absolutely no difference. Efficacy wise, when we are talking about reduction of intraocular pressure, and this is something that you find across the board, you will not find a single study which actually shows that one combination is actually better than the other. What you generally also find is that in almost majority, more than 90%, if not even 100% of the trials, you also find higher incidence of stinging and burning sensation with dorzolamide timolol fixed combination, which is expected because dorzolamide individually has been around for a long time. This combination has also been around for a long time because of the acidic pH. Therefore, as far as installation is concerned, ocular comfort on installation is concerned, stinging, burning, these sensations are much less in the dorzolamide timolol group compared to the brinzolamide, higher in the dorzolamide timolol group compared to the brinzolamide timolol group. And therefore, that is a good alternative. That's all. There is no question of saying, because on one hand, you also consider the fact that because it's a suspension formulation, you will also produce some degree of temporary blurring of vision while you're instilling brinzolamide timolol combination. So whenever you prescribe the dorzolamide timolol combination, you specifically warn patients about stinging and burning that might happen. And similarly, when you are giving the brinzolamide timolol combination or brinzolamide separately, you tell them that is suspension and therefore it can cause a temporary blurring and there's nothing to worry about that. So there is no question of one thing that is better than the other.
Another thing is this dosolamide ideal dosage is 3 times, no?
That is equal for both borzolamide and brinzolamide. In both their clinical trials, when they were used as individual drugs, both of them were dosed thrice daily.
Okay. Okay. Thank you.
So does this combination have symbiotic effect on each other? Like timolol has this long-term drift and short-term that efficacy goes away.
Yes.
So is there, and also timolol is helping in the increasing the vasoprotective effect of brinzolamide. Are there some studies
that timolol increases the vasoprotective effect? Okay, this ocular blood flow vasoprotective effect is a very complicated topic. I mean, I have burned my fingers and hands and every part of my body.
My hairs are gone.
Going through it. Okay, so this is my my understanding of the ocular blood flow situation by reading a lot of literature. The first question is, generally, do topical carbonic anhydrase inhibitors increase ocular blood flow? So let us consider brinzolamide and dorzolamide separately here. So if you look at all the trials, 57% of brinzolamide trials show that there is an increase in ocular blood flow. With dorzolamide, the percentage is like 75%. All right, so there are a greater number of trials with dorzolamide shows there is an increase in ocular blood flow. The second question is the increase in ocular blood flow independent of IOP reduction? Because even when you use prostaglandins in some trials, there has been improvement in ocular blood flow parameters. I think there is an effect of topical carbonic anhydrase inhibitors independent of IOP reduction, because when you compare, say, prostaglandin with the topical CAI inhibitors, when you compare these two groups, the effect of intraocular pressure reduction with prostaglandins is much higher, whereas the impact on ocular blood flow parameters with the topical carbonic anhydrase inhibitors is much higher. So there is some effect that is independent of intraocular pressure reduction. So whether this ocular blood flow increase is going to finally help you preserve visual fields more is the big question, right? If that is the case, then the carbonic anhydrase inhibitors should become one of the first-line drugs in the treatment of glaucoma, not prostaglandins, but prostaglandins still remain the first-line treatment. So unless there is a clear establishment of the fact that an increase in ocular blood flow parameters helps to preserve visual field over a long period of time, topical carbonic anhydrase inhibitors will still remain second-line drugs. And this may not happen very easily, because it was known that if you reduce IOP, that your glaucoma is going to progress less. That was postulated nearly 100 years back, but it took the EMGT trial, etc., in the late 1990s to actually establish this as a fact. Right. So if you are talking about ocular blood flow parameters, people have been actually measuring ocular blood flow parameters for only 20 to 30 years. In fact, there is not even very good databases on ocular blood flow parameters. What are the normative databases?
Yeah, we need more meta-analysis. Yeah, more clinical trials.
Parameters. Yeah, but there is the study called the Leuven study from Belgium, which was published in 2016, which is the first large database of ocular blood flow parameters in open angle glaucomas, ocular hypertensives, controls, etc. So that is, I mean, published in 2016. So we have a long way to go.
What about ROCK kinase inhibitors?
ROCK kinase inhibitors on ocular blood flow. Okay.
Some neuroprotective effect is given for that.
The neuroprotective effect and ocular blood flow are two separate things. Neuroprotective effect generally a protective effect that is independent of ocular blood flow. Well, that is actually studied also differently. Generally, you crush tissues and then try to study the neuroprotective effect.
That
Example.
is basically apoptosis that you're studying.
Yeah. So there it's different methodology. Ocular blood flow is a different thing. There are initial reports that the ROCK kinase inhibitors might have an impact on ocular blood flow. If you notice, if you look at prostaglandins does reduce IOP, and when you reduce IOP, there is some impact on ocular blood flow. That is there, right? But prostaglandins also raises the episcleral venous pressure, which is actually counterproductive. Right, it raises the episcleral venous pressure, whereas ROCK kinase inhibitors not only reduces IOP, not to anywhere near the same extent as prostaglandins, but also reduces the episcleral venous pressure. So there is some preliminary data on the fact that the Rho kinase inhibitors might have some impact on ocular blood flow. Again, whether this actually has any extra effect in producing preservation of your visual fields of a patient over a period of time is unanswered and is not going to be answered for a long time.
But that is because Rho kinase is a
But their IOP lowering capacity is quite low.
Yeah, in compared to prostaglandins, there's no comparison. The Rho kinase inhibitors, if you look at all the trials, they compare Rho kinase inhibitors to timolol, and they found that it is non-inferior to timolol. So that is how the Rho kinase inhibitors trials are. In fact, in the trial that they compared Rho kinase inhibitors to latanoprost, latanoprost was clearly superior.
Arvind, one question. Postoperative intraocular pressure spikes post cataract surgery. What's your preferred medication? Topical medication?
It's timolol.
Any role for Rho kinase inhibitor? Basically, like at least theoretically,
it has that endothelial protection. There are few studies there which are mentioning that it has very good endothelia protection. That thing is there. One action is there. It's been proved in many studies, but all in animal models, not in humans.
Studies are there with obviously with Rho kinase inhibitors intracamerally given, it improves endothelial status, it grows back, and also theoretically, possibly, maybe initially because there is it's a bit of inflamed eye. There can be a bit of egress into the and probably it might help. Kiran, your opinion?
Yeah, the patient is already going to be on steroids, so I don't see a problem with using Rho kinase inhibitors in the postoperative. Otherwise, otherwise the eye will become red very fast.
Yeah, see, when postoperative, if you use it, they don't complain.
Because the patient is already going to be on steroids, so it is not a big issue.
But otherwise, you use it separately.
But then, see, my personal opinion is that we don't know about Rho kinase inhibitors in the postoperative period. We know that we have been using a lot of other drugs for a long period of time for our post-op cataract spikes. So in post-op patients, I generally stick to time-tested modalities. I am not going to experiment. I leave the experimentation to others. And
no, I do it regularly. That's this is my preferred treatment these days. Unless it doesn't bring down to my desired level, I just give it postoperatively. If I expect postoperative spikes, I just add it to the postoperative medications even before I check it the next day. It's there. It's not going to do harm. It might help also.
In general, I don't know whether this is very scientific, but in general, whenever there are post-op spikes, I generally prefer using a combination. And generally, I prefer the timolol brimonidine combination unless there are specific contraindications.
That's my second question. See, Arvind and Kiran, what is your obviously something like latanoprost or prostaglandin analog is the first choice. As a second drug, any
glaucoma. Okay.
What is this choice number 2?
Okay. In my case,
add on.
Yeah, this is a little complicated. I mean, what I mean to say is I generally like to add timolol as an unfixed combination because in terms of intraocular pressure efficacy, if you look at our own experience and a lot of meta-analysis, the second best drug in terms of intraocular pressure reduction is timolol. Generally, the other drugs like brimonidine and carbonic anhydrase inhibitors, whatever said and done, in meta-analysis always shows lesser efficacy than timolol. The problem is when I have to add the second drug as timolol, I generally like to use it as an unfixed combination because, as I said, the combination does not seem to work that well. So my problem would be choosing between timolol or the carbonic anhydrase inhibitors. I generally don't add brimonidine as a primary drug or the second choice drug because brimonidine allergies are too common over a period of time. If you follow patients with brimonidine, literature says average allergies over a period of time is between 15 to 35%. Obviously, with lower doses of brimonidine currently available, it's not that much. But if you are a glaucoma practitioner who sees patients over a long period of time, the brimonidine patients over a period of time tends to complain of these allergic symptoms much more than any of the other people. So my choice is between carbonic anhydrase inhibitors and the timolol. Carbonic anhydrase inhibitors because you can, because there has been some data that this combination actually works very well, better than prostaglandin with timolol. But again, that is not very clear. The advantage with timolol is you can theoretically use a fixed dose combination. That is very advantageous, because if you are using say dorzolamide or brinzolamide as the second line of drug, you are at least dosing it twice, if not thrice daily. So the total number of drops is going to increase from 1 to 4. If you are using the prostaglandin timolol fixed dose combination, it's just 1. So that is a bit of a confusion for me. As long as I feel the patient is comfortable and going to be adherent, I will actually use the unfixed combination of timolol and prostaglandins as the first line of when I have to add.
Is there any clarity as to why brimonidine causes these late allergies? Because we see it, like you said, almost in I think around 70 to 80% of our patients who are long term, they get these allergies with that excoriation around the lid and etc.
Yes.
But why does it happen? Because it does. Because if you really think about it, allergies, they should be there right from the beginning. Why is this a late development?
Immunologically, I'm not very sure, but I suppose there are so many types of hypersensitivity, right? So the late type of the type 4 and other type of hypersensitivity, which mirrored by the T cells, I suppose, is much more with brimonidine. With prostaglandins, the advantage is that generally they tend to create problems, hyperemia, etc., from the very beginning.
Exactly.
So you know what you're dealing with.
Any allergy per se, you would expect it right from the beginning, unless of course, so this seems to go against the grain. Yeah, that is why I. Any other questions? Right. One last question to Dr. Maurya. Doctor, when you are using the Ologen, do you prefer to cut out the tenons, or do you put the Ologen under the tenons?
No, that space should be tenons free.
So you remove all the tenons and then put it over the just under the conjunctiva, right?
Yeah.
Thank you.
Thank you.
Question to Arvind. How did you celebrate your wife's birthday today?
I will be scolded by her. Why you are sitting in a webinar on my birthday?
Okay.
So I think we should be extremely grateful to him for surviving.
We all wish her a happy birthday.
Very happy birthday.
Thank you.
Thank you very much.
So I think,
shall we move on to the next?
Yes. So will you be taking over, Sudha?
No, you can continue.
Okay, then our next speaker is from the postgraduate student, and who will be presenting who is presenting today?
Hello, madam. Hello.
Am
I audible?
Please go ahead. Yes, please go ahead.
Good evening, all. I'm Dr. Manna Maria James, Junior Resident at Government Medical College, Thrissur. And I'll be presenting the case. Is my screen visible? Hello?
Yes, visible.
Okay. I'm here to present a case of a 29-year-old male patient who presented in our OPD with history of sanitizer falling into the right eye during the month of November. And he was complaining of decreased vision, mild pain, and redness in right eye. On examination, the right eye showed mild haziness of cornea, and he was treated symptomatically, and the patient improved. After 2 months, during the month of January, the patient returned with colored halos, headache, and defective vision. On examination, the right eye showed corneal edema, IOP was normal, and the anterior chamber depth was also normal. So he was diagnosed as secondary inflammation to the chemical injury and was treated with steroids and cycloplegics. 2 weeks later, the colored halos increased in severity, which was associated with headache, but not associated with vomiting. The symptoms were more during the morning, mainly on waking from sleep, and also present during evening hours. On examination, the AT was 50 in right eye and 14 in left eye. The patient had a family history of glaucoma for his grandmother, and she has undergone surgery for the same. And so now he was diagnosed as suspected steroid responder, even though only 2 weeks duration. The steroids were stopped, and he was continued on treatment with anti-glaucoma medications like tab diamox, timolol eye drops, and hypersol eye drops. And there was no history of any trauma, no usage of any chronic medications or drug addictions. There's no history of flashes, floaters. There is no history of using spectacles. No history of fever, joint pain, difficulty in climbing steps. On detailed ocular examination, the vision in right eye was 6.9 and in left eye it was 6.6. Near vision and color vision were normal. The conjunctiva showed mild conjunctival congestion. The cornea in the right eye showed mild corneal edema. There was no evidence of any keratic precipitates, gut tape, pigments in the corneal endothelium. The anterior chamber, peripheral anterior chamber depth was less than half corneal thickness in both the eyes, and also the central anterior chamber depth was normal. Iris showed loss of normal pattern in right eye and was normal in left eye. Pupil was normal, and the fundus examination also showed normal. Apprenation tonometry in right eye showed 34 in right eye, and left eye it was normal, that is 14. Gonias showed normal angles, closed angles in right eye, and in left eye it was grade 3 open angles in inferior and nasal quadrants, and grade 2 occludable angles in superior and temporal angles. The axial length was more towards the hypermetropic side, and the anterior chamber depth was normal. The patient was started on pilocarpine. PI was done after 1 week in right eye, and the patient was reviewed after 1 week. The AT at that time was 26 in right eye, and in left eye it was 14. And the patient was on timolol and pilocarpine eye drops. And the slit lamp examination showed a patent PI at 11 o'clock position, and the ASOCT was done, which showed narrow angles and a partially patent PI. So the PI was repeated. The slit lamp photo showed a PI at 3 o'clock position, and the ASOCT showed a patent PI. And now the patient is having an AT of 20 in right eye and 14 in left eye, and the patient is on Dorsox T eye drops and pilocarpine eye drops. The ASOCT of left eye was showing narrow angles, and prophylactic PI was done in left eye. The differential diagnoses are primary angle closure disease in right eye and angle closure suspect in left eye, and also Chandler's disease. On to the brief discussion about the diseases. Primary angle closure disease. It is a disease of mainly of elderly age group, and according to a study which was conducted in China, which was published in International Journal of Ophthalmology, the study showed that about 90% of the people were belong to the elderly age group, and only 10% belong to the young age group. And the age of 40 or less was defined as younger patients, and the predisposing factors in young mainly included short axial length, shallow anterior chamber, thick lens, forward positioned ciliary body. And next is about the Chandler syndrome. And it is a part of IC syndrome. It is a group of disorders containing 3 clinical variants, that is Chandler syndrome, progressive iris atrophy, and Cogan-Rees syndrome, which basically have manifestations mainly in the cornea and the iris. And the Chandler's disease is the most common, accounting to almost 50% of the cases, and typically presents with greater degree of corneal pathology and also associated with corneal edema. Iris findings are very less common in case of Chandler syndrome. Thank you.
Thank you, Dr. Manna. The case is open for discussion.
Basically, this came as a surprise because we thought it was some sanitizer injury, and a young patient, we didn't think of angle closure immediately. That is why we dilated the patient, mid-dilated position. He returned back, and then also actually first time I think we missed doing the gonioscopy. Only after doing the gonio we found out that it was closed. So we were wondering like why 50 tension he's coming back with. So how common is young angle closure?
Yeah, a couple of comments, madam. First of all, I mean, she mentioned that it was grade 3 angles. So what does that mean actually? What grading is that? I didn't get that. Doctor, it's best to always mention the structure you have seen on maximum indentation at least, because this will, when you present your case for your exams and all, you will end up in trouble when you say that this is a grade 2 or a grade 3. Then they will ask you what grading are you following, you know? Because you said that the left eye was grade 3 angles, infronasally. So
In 2 quadrants, it was grade 3.
so grade 3 means what does that? Are you seeing the scleral spur or?
No, ciliary body band.
You're seeing up to the ciliary body band. Okay, that is on indentation.
Yes, no, not indentation. Yes, sir, on indentation.
Okay, all right. Okay. Okay. The other thing is, I don't know whether I missed this. Do you have the biometric parameters, action length, AC depth, etc. of this particular patient?
Yes, sir.
Yeah. What was that? What was the action length like?
The axial length in right eye was 22.9 and in left eye it was 22.5.
The AC
and
depth?
the anterior chamber depth was 3.47, 2.47 and 2.55 in right and left eye.
Okay. I was just saying that does not come under, classically come under what we call as, eyes predisposed to angle closures. Generally, you get much lower axial lengths, and certainly the AC depth of less than 2 is pretty common in angle closure disease, but in younger patients, it can be slightly higher. Yes.
So what you learned from this case?
So we can have angle closure disease even seen in case of young patients. That means even with very minimal manifestations, even with a normal anterior chamber depth, the gonio should be done. The gonio can show closed angles in such cases.
Very good, very good, very good, excellent.
And Dr. Manna, just one thing, you mentioned about that article in, a Chinese article, which actually looked at angle closure disease in the young. Do you remember what was the commonest cause of primary angle closure disease in young? What is the commonest cause?
It was mainly plateau iris configurations, and the people were more belong to the hypometropic group.
Yes. Plateau iris is the commonest cause of primary angle closure disease in the young. So in this particular case, did you notice any plateau iris configuration on gonioscopy? I mean, at least in terms of the classical signs of plateau iris, may not be always visible, but
the sine wave pattern was not that appreciated.
Okay. I just wanted to ask that. So one thing you mentioned is that in your examination later, you mentioned that the peripheral, when you looked at the Sritlam-Van Herk, you found that it was actually the peripheral anterior chamber depth was less than half of the corneal thickness, right?
Yes,
yeah.
Sir.
So if you go through the Asia Pacific glaucoma guidelines, one of the things that is clearly mentioned is that for all patients, gonioscopy is not practical in all patients who come to the OP, but certainly you can have a quick look at the Van Herk. All right. And one might think that this is a very simple thing to do, but a positive Van Herk, that means a PAC of less than half of corneal thickness, is actually quite predictive. It has a very high sensitivity of nearly 90% to actually pick up angle closures. So that is, I'm just giving it as a pointer. This can be actually be done for all patients, right? A quick look at the peripheral anterior, this thing. And plus you also mentioned that in spite of the peripheral anterior chamber depth being less than half the corneal thickness, the central AC was deep.
Yes, sir.
That is classically what you would expect in a, plateau iris in general, with the central AC going slightly deeper. Obviously the plateau iris can be confirmed only on a UBM, and ASOCT is not going to help you.
I think that was very useful discussion. Any other questions?
Another thing is this topiramate any history of intake of drugs like topiramate is also very important, especially in young patients presenting with a bilateral angle closure.
Yeah, a drug-induced, the classical feature of a drug-induced angle closure generally tends to be bilateral, and two, there will be a myopic shift. So when you do refraction, you will actually classically find a myopic shift. The important thing is these are the two things that you immediately come to mind when you see a bilateral angle closure with a myopic shift. When you see that, you suspect drug-induced. But the thing is, practically there are a lot of drugs that can cause this. Topiramate is the most well-known. The first publications were on topiramate, and the most number of publications have also been topiramate. But there are, the second most number of publication on which drug? I'm just asking you. Of course, this is not an exam question or anything. It's a very informal thing. Okay, the second most common drug that has been associated with bilateral acute angle closure. You'd be surprised. It is acetazolamide. All right, a drug we actually use for treating glaucoma. It is the second highest number of publications, if I remember correctly. And plus, you can even in the literature on drug-induced angle closure, you have even a dietary supplement, which is used for anorexia. Ecstasy, your recreational drug use, which actually becomes more important now because drug abuse is a problem in all the urban centers in India now. Even ecstasy has been known to actually cause this.
Right. So any other questions? So Manna, very well presented.
Thank you, madam.
And I think that brings us to the close of a very, very interesting evening. Thank you very much, Dr. Sudha, for giving me this opportunity, and really enjoyed the wide-ranging discussions. And so thank you, everyone. And Dr. Sudha, please take over.
Thank you, Dr. Merin and Dr. Srini, for chairing the session. And I think we go on to Dr. Rama. Will you give us a vote of thanks? Chairing the session, and I think we go on to Dr. Rama. Will you give us a vote of thanks?
Respected ladies and gentlemen, warm good evening to one and all. I'm here to propose a vote of thanks. First, let me place on record our sincere gratitude to our guest speaker, Dr. Arvind Kumar Moria from All India Institute of Medical Science, Hyderabad, for his excellent talk on phacotrabeculectomy with Ologen and the very good quality videos. Thank you very much. Let me express a heartfelt thanks to Dr. Kiran Gopalakrishnan for enlightening us by his wonderful talk on 6 drug combinations. Thank you, sir. And I thank Dr. Manna Maria James for that nice case presentation. Let me thank our chairpersons, Dr. Merin and Dr. Srini, for chairing the session. And thank you, KSO's office, for giving us the platform, virtual platform, and the technical support. Let me express our sincere thanks to Dr. Bastin and Dr. Tanusri for all the arrangements for our academic meet. And I thank the Novartis for their contribution to our academic meet. Lastly, but very importantly, let me express my sincere thanks to all the senior members, KSOS members, Dr. Gopal, our TACOites and PGs who made this function a grand success by their presence. Thank you all. Thank you.
Thank you all, and I think this was one of the best attended meetings online, at least. When many people will watch the YouTube later, but the Zoom meeting, I think it was very well attended. Thank you all for joining in. Thank you.
Tell Arvind, tell Sneha that it was a very good meeting. And
yeah, right.
Happy birthday. Thank you so much.
Thank you so much. Bye.
Bye.
Thank you and good night, everyone.
Good
Stay
night.
safe.
Okay.
Stay safe.
Tell Sneha that it was a very good meeting.